Welcome to my talk. So far, it's a great event. We've seen quite some spread in topics and how where RAG can be used. Essentially, now I want to add a healthcare perspective. So the talk is entitled From Concept to Care, GenAI-Driven Innovation in Digital Health. So concept to care essentially means you have an idea, but eventually that should help the patient in that specific context. That would be a precise, timely, accurate diagnosis. And GenAI-driven innovation in digital health here in that sense, the context that you're going to see is inspired by radiology. So radiology, maybe a few words here. Basically, the data is immediately patient-centric. So you double-click on a file. What you see is literally the lung, the heart, the liver of a patient. So then you have metadata as context. And so you're very close to patient data. And also the upstream data generation. Where does this come from? From radiology machinery, so to say. So that's CT scans, MRI scanner, X-ray. So those machines themselves served a couple of researchers very well. They were actually worth a couple of Nobel Prizes. And that means there is a whole science upstream of the AI part. It takes years of training to do those image acquisitions right. And accordingly, the file formats are a bit a beast to handle. And that's basically as a pretext for what I'm going to show in the next couple of minutes. But basically, radiology in that sense comes with some extra implications. So let's see. Yeah, okay. Maybe a few words around Bayer as a company. Yes, so the mission, bottom left, health for all, hunger for none. It indicates basically the two dimensions that the company has. So health is healthcare. It's over-the-counter business. Aspirin is one of the most known products. And then there is also prescription drugs. Hopefully none of you will ever use them. So if you are dependent on those prescription drugs, it means either you're in an intensive care unit or have cancer. So that's stroke medication, heart attack, cancer. And hunger for none links to the agriculture technology business, and Bayer is actually the largest agriculture company in the world, and probably like most of us, or at least 50% of the people here, have been touched directly or indirectly by a Bayer product today. So specifically, whether you go via Uber or Lyft or Airbnb or Booking.com, you have to eat. And basically the food, independent whether it's rice, corn, soy, has been grown by a farmer. And as a largest seed producer, those seeds were most likely coming from Bayer. And also the crop protection is very strong in Bayer. So overall, the company has 100,000 employees, 5.5 billion investment in R&D, and around 50,000 billion sales per year. So it's a very broad spectrum. What I enjoy about this company is basically with its 160 years of history, it has learned to adapt technology. So whenever there's a new technology coming, it's just taken, it's put into context of certain research, and then if there's new research coming, then we just swap. So I started off with support vector machine, then it was CNNs, transformers. Now GenAI basically is just the next step. Now let me slightly switch gears to healthcare and radiology. I want to motivate a bit where I'm coming from. So we see $1 in $4 invested in healthcare venture capital goes into healthcare AI companies. And basically that leads to a huge push. And throughout the last 3 to 4 years, we've seen 950 approved AI-enabled medical devices. Approved means they can be used in the clinic. They have market approval. And among those approved products, 75% feed into the radiology domain. Medical devices is a term for diagnostic software. And approved by whom? By a regulatory body. And by now, FDA almost became a household name. It's the most famous regulatory body, Food and Drug Administration, and they also have the wonderful task to now validate all those AI solutions. So sounds all great and fantastic. Despite we see a failure rate of 80%. That means we have a huge survivorship bias. Only the 950 are the ones that made it to the finish line, that got the approval. But majority is actually not even, is not capable of reaching that finish line. And yeah, but we at Bayer, we looked into this. I think it's kind of sad. We need to improve. And we analyzed what are the reasons contributing to this high failure rate. And yeah, the analysis that we did internally, we talked to our partners, we looked into literature. It's multifaceted. And reasons are lack of experience, data science capabilities, but more pronounced in even regulatory experience. So how do you need to how do you need to code a solution to be able to get the market approval down the line, maybe 1 year later, 2 years later after initiation of the project? Same, how do you get it reimbursed? So the payers, it could be public healthcare providers as well as health insurance, they have their own guidelines saying, I'm only going to pay for the usage if you follow those and those rules. So basically, if you do a naive project development and you reach the last mile, it might be that you find out about certain things, you need to go back to square one. And of course, you're running out of time, running out of finance, resources, and that's hugely ineffective. And then there's also a lack of expertise once you need to do clinical performance testing. And this is basically following a set of rules established over decades. This is informed from drug trials. And it's not just measuring on the golden holdout data set. You actually need to deploy your solution in the clinic. You have clinical trial managers, you need to log, you need to document all that. So this all adds on the complexity. And yeah, there are a couple of more inefficiencies like contracting, just the setup of the working environment, so HIPAA and GDPR compliant data storage. And yeah, this piles up, and also eventually the cost barrier is very prohibitive. So it takes 2 to 3 years, $3 to $5 million actually to get to that market approval. And I mean, eventually innovation and patient care does not have time for setup. So we thought at Bayer, well, can we improve? Can we optimize? Can we build a platform that basically increases the degree of automation? And we think that's absolutely possible. So the working title of that platform is AI Innovation Platform. It's informed and built by data scientists for data scientists. And yeah, we try to decrease this failure rate. So this is just a very high-level view of the development journey. No surprises, essentially. So user starts from the right. The lobby now refers to a landing page, landing zone on our platform. But essentially, you will then have the data work. Either bring your own data, buy data, you license data. Probably it's a mix of all of them. You need to then do the regular data work. Then there is the model aspect. It's not linear, obviously, you go in circles. But then there comes a point, the orange boxes, where you kind of have a code and model freeze, and then you prepare for the market approval and for getting the documentation right. And basically at that point, the development team is forced to just be hands-off. And the clinical performance validation, then a whole new team comes in, does the protocol, and goes out to the healthcare professionals. And it very well be that also from the notified body, you get information back, well, you need to change something. And the idea actually, and now I'm relating back to RAG and knowledge workers, ideally some of the critical knowledge on the last mile is already available early at the start. So you basically have a way to inform developers what is needed down the road. And that's what we tried with that platform. This is a very crowded slide, but essentially we have different workspaces and columns on that platform. So we do the development itself, we have the infrastructure, and then the validation part is basically a lot of human knowledge worker work. So writing protocols, writing documentation, all that. Also the integration in the clinic, how to serve, how to install software in the clinic. So it's not a Git clone or right-click download. That's not how it works. Exactly. So the task is complex, but it's not complicated. Essentially, if we connect a lot of dots, at some point we have it, and we can reduce this failure rate. And also what it shows, there are many bubbles of specialized knowledge. So it takes a village to build a diagnostic tool. But those bubbles, if we work smart, they can be put at the right place. So essentially we do this and we try to solve this with a standard solution stack. There are no big surprises. So we have the templates, the chat window, chat assistant. The documents are chunked, indexed, all that. And then we have a place where basically we have different vector stores. We have Elasticsearch, but they are basically tagged and they have their own governance layer around it, and you can mix and match depending of the stage where you are in your life cycle. And that's basically how I see knowledge. So it's not static, it changes. It's bubbles, and basically what you can then also see, the bubbles have different size. The bubbles can be homogeneous or heterogeneous, or some bubbles can be fused because they're very similar or should stay separate. So knowledge, in a sense, is a compartmentalized asset, which can be moved around. So now, even one step back, our platform has different users. They are isolated, so it's a multi-tenant setup. So we have that replicated multiple times on the same platform. And the standard, the tech stack is the tenant isolation happens by a GCP project, LangChain lib, wrapper code, custom adapter code. No surprise here. The knowledge bases can either be global across project, that means within Bayer or within Harvard Medical, they have a global knowledge base, or they can be project specific. So only oncology, only neurology share certain knowledge. They can be static or dynamic, or platform curated, or customer generated. And last paragraph, those knowledge bases, vector stores, they are equipped with opt-in, opt-out toggles. We have tags, so they can group them, and sharing functionality. And essentially, this is then what it looks like. We have on this bubble space different of those entities. And that opens up a couple of scenarios that I want to walk you through. So now knowledge can be handled, and you can merge and separate it. And it's like if you share knowledge between two organizations, companies, it's like merging two galaxies colliding. But you can now do this in a very graceful way. So I want to walk you through a couple of scenarios. The famous saying, "Don't repeat the same mistake twice," usually implies per individuum or per person. But now you can do this per team or even between two teams. So by abstracting the knowledge a couple of layers up, you can even do this only between two departments. So if one mistake was done maybe in the neurology department, like even all your colleagues can benefit from it, or between two companies. Another scenario is a pay-per-knowledge scenario that I can think of. Basically, one can now monetize domain expertise across organizations. For instance, weather modeling exists in agriculture technology, but it will be also relevant for renewable energy, for insurances. So why not serve knowledge through an API and monetize it? Another part is how to manage knowledge in terms of integrating two parties. For instance, merger and acquisition. Usually it takes years till you have the knowledge synergies, and you need to move people around to make it work. But basically, if it's compartmentalized, that should be way easier. And also the arm's length concept that exists in healthcare for sure is now way easier. Arm's length means you buy a junior partner, but you don't want to outnumber the talents by corporate brains, so you keep them separate, but they still should have the benefit of a large organization, like big account pricing at GCP, or partnerships like mutual partnerships or consortia. You also want to change knowledge, but only certain knowledge. Lastly, team internal communication, which should feed into improved innovation. So from research, we know a team size to innovation ratio plateaus at 7 to 8 team members. Then the quality of the communication breaks down. Maybe with basically this abstraction, we can lift this up. Teams can grow much bigger, but keep the output of innovation because the high quality communication remains. 2 minutes, awesome. This works. Yes, now slightly switching gears. So how is this enabled? How are we using Deep Lake specifically? So my top 3 Deep Lake features to do all this. Number 1, the multi-source queries in TQL. Pretty simple from code-wise, but basically very, very powerful. So you can actually put in different data lake objects, but then do one query on all of them. So a group, a set of knowledge. And I think what David showed earlier today, that kind of is the embodiment of this. Tensors with links, so you can have distributed data assets, but build one unifying data object. And it can be in different cloud providers and local, so that's good. And federated credential, that's a bit like mundane, but we use it very often. So basically on the GCP level, we can decouple knowledge from projects, from individual developers, from units. So I can highly recommend you to look into this. And what's next? Next week, there will be a hackathon in Munich in the Google offices. And for more information, there is a URL. We have launched a alpha tester program, and some more information on the next slide. But if you're interested, you can reach out to me, talk to me, and there will be a lot of live demos, presentations at the largest radiology conference later this year in Chicago. The alpha tester program. So that's actually the highlight of the talk, maybe. So if you know someone or you personally, you want to go into the healthcare space, if you're building, prototyping a model, but you're not sure like what else is needed, how do I actually get market approval? So we have this alpha program. It's very cost efficient way to start your journey. So we share cloud costs 50-50. That's that. You have direct access to medical, regulatory, reimbursement experts that are in our company. We do have ex-FDA people in our ranks, so you can Q&A them to sharpen your product. IP consulting, market access consulting, what's the pricing, etc. So this all comes with the Pioneer AI program. And what we need is true commitment to work on that platform, on your project, and provide feedback. So we want to make the platform way, way bigger. Time is up. Summary. Improve development tools to get those 80% failure rate down. Summary 1. 2, treat knowledge as a fair asset, similar to data products. And modern AI databases like Deep Lake need to have certain features to basically allow this knowledge sovereignty and distributed governance of those assets, similar what we know from data measures. With that, thanks for your attention.